I'm delighted to be here this weekend presenting the results of the CD8 trial. It's really a trial looking at a single dose, so one dose of Ipilimumab and Nivolumab in patients with resectable melanoma. And the fancy kind of part of it is the additional imaging with it, where we're doing CD8 PET in conjunction with this treatment in a phase 2 trial. So really, we know from this time last year here at ASCO, our colleagues from the Dutch group, Dr. Blank presented the Nadina trial, which was a phase 3 study of 2 doses of Ipilimumab 1 milligram and Nivolumab 3 milligrams per kilogram. And it showed that it was superior to surgery followed by PD-1 alone for patients with resectable melanoma, and showed really impressive high pathological response rates of about 59%. And what we know is that comes with about a 30% grade 3 toxicity, like grade 3 or higher toxicity rate. So that's moderate to severe toxicities for our patients in a curative setting. And then, there's been multiple studies done in the neoadjuvant setting, be that the SWOG 1801, which looked at pembrolizumab monotherapy 3 doses before surgery, and then completing out the year afterwards. And again, really impressive, superior to adjuvant treatment alone. But I suppose the combination of these and other phase 2 studies is that we don't know what is the right dose and what is the right combination of drugs for our patients. Who do we pick? Who is pembro monotherapy enough for? Who needs the Ipi-Nivo? How do we tailor and personalize and drive forward, improving our patients' outcomes, maintaining this efficacy, building on it even, and reducing toxicity? So that's kind of where the idea for the CD8-Neo comes from, where we're doing 1 dose given pre-surgery. So they get 1 dose and then 4 weeks later undergo surgery. And what we've shown in this is interim results. So the plan for the study design is 28 patients total. It's a Simon 2-stage design. So we've completed stage 1 and we're in stage 2. And the reason we're presenting it is because we've had over 12 major pathological responses, which meets the study's primary endpoint for positivity, which is really exciting. And we're delighted to be presenting that this weekend. And that's showing very similar, 59% of our patients had a major path response, and only 9% of our patients had a grade 3 or higher toxicity while on treatment. So, I think this is encouraging preliminary, single center, single arm trial, but a really encouraging sign of efficacy of 1 dose. And I would emphasize the dosing of we giving a higher dose of Ipilimumab than was given in Nadina. So this is kind of the secondary endpoints of the trial. We looked at, how standard response on CT imaging. And across all the neoadjuvant studies I've mentioned before, Nadina, SWOG, we've seen this discordance between radiographic and pathologic response. And that's, when we're doing our standard CTs before we take them to surgery, most patients firstly have stable disease, and we don't know what that means. And some people are coming out with major path response with no viable melanoma, and some are coming out with pathologic non-response and not having had a benefit. So it's we saw that as similarly in our cohort, small cohort again, but that the radiographic response didn't predict pathologic response for the majority of patients who were stable. And that is where some novel imaging comes in. And that what we have is a CD8 PET tracer. So it's given to we did in our patients, and 19 patients completed the baseline CD8 PET, so prior to receiving immunotherapy, and a further 17 had a matched or paired CD8 PET prior to surgery. And what we did initially is we looked, that first step of, does this tracer actually show us CD8 cells? And that was our first kind of port of call to make sure that we're looking for the specificity of the scan. And we looked at patients' tumors and we stained their tumors for CD8 cells and had a pathologist quantified CD8 staining. And then we saw the uptake of the tracer by autoradiography. And we showed a strong correlation between CD8 cell infiltrate and the intensity of tracer uptake by autoradiography. It's kind of a proof of concept, proof of principle that we're seeing when we're doing the scan, we're seeing what we want to see, and that's CD8 cells. However, in that small sample set, we did try to look and see, could the CD8 cell infiltrate predict pathologic response or be associated? And we didn't at baseline or pre-surgery see an association between CD8 cell infiltrate and uptake, or some of these imaging measurements such as SAP max or mean standard. So that's the initial results. I think there's a lot more to be dug out of these scans, and a lot more analysis that we're doing and working on in order to help us figure out how best to use this tool, both in the neoadjuvant setting and in others, in both melanoma and lots of other cancers where, the role of understanding what the immune system's doing and having a non-invasive tool to serially measure it is really exciting.